Hi everyone. Hello. Has anybody come live? If yes, then just they can give me a thumbs up. And as soon as I know that you guys are here, then we'll start with our discussion of the questions that came in NEET PG 2024. I'm going to wait for a few minutes before we can start so that everybody joins in. Hi everyone. Is anybody live? If yes, then they can just give me a thumbs up. If audio video is fine, I can see my video. I see few people who have joined in. If you can hear me, if I'm audible and visible, just give me a thumbs up so that I know that you guys are here. And we will start with our discussion of the anesthesia questions that came in your NEET PG 2024. All right. So I welcome you all to this session of the NEET PG recall, and we discussed one aspect of it on the day of your exam when we discussed quickly through what came, and now I'm going to put you through this detailed discussion. Before I go ahead, I just want to point out what I've been saying since years is that don't leave anesthesia. It's an easy subject. It's a subject where what we read, what we discuss, what we write is what is being asked in the exam. And most of the time what we discuss is what is being asked, and the things are, the questions are very, very predictable. And I've been predicting that complications, CPR, critical care, these are the things that are going to be asked more in these exams. And so this is what we are seeing right now. We are seeing a total of 2 sessions that happened for the exam. Just a second. A total of 2 sessions. In both the sessions, there were very equitable distribution of questions. Both sessions saw 6 questions each. And if you look at the breakup, then everything was similar. Airway management, we got 2 questions in both sections. Regional anesthesia, 1 question in both sections. CPR, 1 question in both sections. Expected question from critical care that has been asked previously as well. This is the question that I have predicted since last year. This was my predicted question on Sugama-Dex, because Sugama-Dex got its approval last year September in India, and I told you that it is going to be asked. And I always say that complications and monitoring are the most important topics in anesthesia. So this is how very equitably the question paper was distributed, and everything that we discuss has been asked bearing 1 question. So let's start with the 6 questions in session 1. Which of the following is the correct statement regarding this technique? And most of the students, so half of the students told me EMLA was written, half of them told me that something like this was written. So just consider that they showed you a patch that is applied on the surface, and looking at the options, you know that they are talking about EMLA, because the option said contains ropivacaine, lignocaine. 1 gram of 5% of this ointment contains 50 milligrams of lignocaine. It is called equal mixture of local anesthetics and has a potential to cause methemoglobinemia. So now the thing is that if you have discussed, if you have read the anesthesia and local anesthetic pharmacology, then this becomes a very correlated question. Why? Because this is a 2-part question. First part was identifying the technique, which was EMLA. And I often tell you then in anesthesia, there is a lot of emphasis on the full forms, and EMLA is not equal mixture, it is eutectic mixture of local anesthetics. Eutectic mixture of local anesthetics, which is 2.5% prelocaine and 2.5% lignocaine, which is mixed in a form of an ointment or a cream, which is used to produce surface anesthesia, that is anesthesia over intact skin. And this is something that I have been discussing since years in the class. So see, this is what I have discussed. This is the snapshot from the class where I have discussed EMLA. You can see it's a topical local anesthetic, which is anesthesia over intact skin, that is 2.5% lignocaine and 2.5% prelocaine, right? So the first option automatically becomes wrong. It doesn't contain ropivacaine and lignocaine. It contains lignocaine and prelocaine. Now, it is not called as equal mixture of local anesthetic, but it is called as a eutectic mixture. So this is also gone. Now the options that remain is this. And I know this option will appear difficult because this calculation is not something that you guys are used to. Although the general calculation is that whatever percentage is being shown, you multiply that by 10 becomes milligram per ml. That is the general calculation that you have to remember, that if they are giving you any drug which is shown in percentage, if you multiply it by 10, it becomes milligram per ml. So technically also 1 gram of 5% of this ointment will not contain 50 milligrams of lignocaine, but 25 milligrams of lignocaine, because this contains 2.5% lignocaine. So 25 milligrams of lignocaine and 25 milligrams of prelocaine. But what is more important is whether you know, and this is something that we have discussed, that only two agents, two local anesthetics are associated with methemoglobinemia, that is prelocaine and benzocaine, and you apply it over skin. Okay, Ramesh. So EMLA was written in the option, so we will write EMLA, no problem. So they gave the image and they wrote the EMLA. Perfect, right? So that automatically becomes the correct answer. And this is what we discuss. See, when we discuss toxicity, then we discuss the first toxicity as methemoglobinemia, which is shown only by prelocaine and benzocaine. So yes, EMLA can be associated with a concept, a complication of methemoglobinemia if you have applied it for a longer time or you have applied a very large dose in a large surface area. All right. So this was the first question that was asked. Question number 2. It is something that we discuss every year. What is the function of PEEP in mechanical ventilation? We discuss it as CPAP. CPAP is continuous positive airway pressure, which is PEEP in non-intubated patient, which is very important part of acute exacerbation of COPD in the mode of BiPAP. And PEEP is when you give a positive end expiratory pressure in a ventilated patient or in a intubated patient, right? So the name only tells you it's one of the most easy things to understand. PEEP is positive end expiratory pressure. So it is telling you that at the end of expiration, we apply a positive pressure. We keep a positive pressure. So obviously, if there is a excuse me, if there is a positive pressure at the end of expiration, so inspiration, air coming in, alveoli expands. Expiration, air going out, alveoli should collapse. But if you keep a positive pressure at the end of the expiration, then the alveoli will not collapse completely and they will always be recruited there, because if they collapse completely, then the force, the pressure required to open them is too high and that alveoli goes into atelectasis. So does it eliminate CO2? It can eliminate CO2 if you apply very large amounts of PEEP, but physiological PEEP doesn't really affect CO2 elimination. Does it prevent collapse of alveoli? Yes, it prevents the collapse of alveoli. It is therefore a very important part of lung protective ventilation. Does it increase respiratory rate? Definitely not. It is just pressure at the end, whatever rate you have set. And does it increase? No. On the contrary, it decreases venous return, because application of PEEP increases intrathoracic pressure. And if the intrathoracic pressure increases, then automatically the venous return decreases. The intrathoracic pressure, if it increases, then automatically the venous return decreases. See, we apply 5 centimeter of PEEP to prevent collapse of distal air spaces at the end of expiration. Something that we discuss every time we discuss critical care in our topic of critical care and miscellaneous. All right. Question number 3. Now, I am very proud of myself because I predicted this question last year simply because of what I saw. I saw in September 2023 that India first time ever gave approval to Sugamadex, and I knew the moment it got approval, it will be available in all medical colleges in India and the HODs will start using it and it will appear in their hands, and so you will get a question. So you got a question in INICET and you got a question now. But see the funny thing, we always discuss Sugamadex as first relaxant specific reversal agent, and it is for ROC and VEC. Although clinically also we most of the time use it for rocuronium, but the question asked vecuronium. Immediate reversal of vecuronium, the answer would be Sugamadex. Answer would be Sugamadex. All right. Question number 4. Identify the following device which is shown in the image. Now, if anybody has seen this device, they will never get confused. It is just a simple airway device which is made up of soft silicon, which is inserted nasally, that is nasopharyngeal airway, and basically both oro and nasopharyngeal airway prevent trunk fall. prevent tongue fall. And we have discussed this many times that whenever a patient loses consciousness, then the upper airway muscle tone decreases and the tongue falls back. And when the tongue falls back, there is obstruction of airway. And you can insert an oropharyngeal or a nasopharyngeal airway to remove that obstruction, to decrease that obstruction by preventing the collapse of the tongue on the posterior pharyngeal wall. So I don't think there was any doubt in what this device would be. This is a very interesting question. It is a pediatric patient being resuscitated in the wards. After one full cycle of CPR, he developed the following rhythm on ECG and they gave you the rhythm. So they asked you the identification as well. What is the next step to do? So there are two aspects of this question. One, the clinical scenario that has been given. Two, identification of ECG. And ECG was easy because it was just random ECG without any PQRST which pointed towards VT. And because resuscitation was going on, so it was pulseless VT. And we know pulseless VT is a shockable rhythm. It's a shockable rhythm. Isn't it? It's a shockable rhythm. Since it is a shockable rhythm, you're supposed to shock. So will you give synchronized shock? No, there is no synchrony. Synchronized shock is given where there is some synchrony. This is totally disorganized rhythm, so no. Continue chest compression. See, you have already done one whole cycle of CPR. Now you have attached ECG. Now you have got a diagnosis of a shockable rhythm. Why would you continue chest compression? You will give shock. Immediately after shock, you will continue CPR for 2 minutes. Remember, immediately after the shock, never check for pulse. Always continue CPR for 2 minutes and then only wait to check for pulse, rhythm and respiration. Administration of epinephrine at this point of time, no. See, the patient was undergoing BLS. You just took over the ACLS and you attached the ECG. So at this point of time, you're supposed to give first shock. Then somebody would start taking an IV line. Once they take an IV line, then they will give epinephrine. So yes, epinephrine is a part of the ACLS protocol, but it will happen only after the second shock. So the moment you take over, you attach monitor, you give oxygen, you analyze rhythm. If it is shockable, this is the point where they have asked you the question. So what is the next step? Shock. What do you do immediately after shock? CPR. Now you will start taking an IV line, then again analyze rhythm. If it is shockable, then shock. Immediately after the shock, CPR. Now somebody would start giving epinephrine 3 to 5 minutes. So you have to understand in this algorithm, where are we entering? And that is how you know. And it's a very intelligently curated question. And I'm very happy that they're asking clinical questions in research, because we discuss this topic in great detail and we know how to approach a patient with cardiac arrest both in BLS and ACLS algorithms. Last question, in a patient with the following pathology, which procedure would be difficult to perform? Now this is also very interesting question, and I know that this was more of a logic based question than a fact based question, and yet a lot of students, they made a mistake. And that is what differentiates the students in the exam. Sometimes we feel कि यार जब recall में देखते हैं तो we feel कि हाँ ये भी बन जाना चाहिए था, ये भी बन जाना चाहिए था. But what goes in your mind in the exam becomes very difficult to understand. Now everybody diagnosed that this is tracheal deviation. Everybody diagnosed that it is a tracheal deviation. And then they thought कि okay, the trachea is deviated, then हो सकता है LMA insertion would be difficult. Most of the people thought that if trachea is deviated, nasogastric tube insertion would be difficult. Now just look at it anatomically. What is deviated? Trachea, right? So anything that you do supraglottic, trachea is infraglottic. Anything that you do supraglottic, will it get affected? No, your laryngoscopy would be fine, your visualization of vocal cord would be fine, your LMA would be fine, your face mask would be fine, your intubation would be fine. Problem will happen anything that you do infraglottic, that is tracheostomy. If it is deviated, you open in the midline, you are trying to find the trachea, but instead of finding trachea, you will keep finding esophagus, you will keep putting your tube in the esophagus. And why would nasogastric tube be a problem? You anyway pass it through posterior pharyngeal wall, which goes down into the esophagus. So it has nothing to do with the deviation of trachea. So the correct answer to this question was plain and simple logical, that is tracheostomy. It was plain and simple logical, that is tracheostomy. So these were the 6 questions that were asked in the first session. And first session I found in anesthesia was pretty straightforward and easy. All 6 of them were doable. Let's come to second session, and now most of the questions are here easy, but you can say that second session was little tricky. What does the marked portion of the capnogram represent? And something we discuss all the time in the class. You start with dead space, then mixing of dead space with alveolar CO2, and this plateau is the alveolar plateau phase. Again, something we discuss in detail every single time, and we always try to understand capnography by these 2 things, thinking like a transducer and starting with expiration. I told you, any capnograph that comes, you will always be able to identify phase 3 is alveolar plateau phase, which is the exact same thing that was asked in the exam. Which of the following position of the patient is used for? Now, I could not get the 4th option, but yes, everybody told me that there was a position of the head of the patient and there were 3 axes which were marked. So they had the markings of oral, pharyngeal and laryngeal axis, and then they asked what is this used for, and there were options related to intubation only. Position for intubation, sniffing position for intubation, position for bougie insertion, position of neck for intubation, and I could not get the 4th option. And see, it is obvious that it is a sniffing position because they have showed you the angles, and we know that the ideal position for intubation we discuss all the time, and we discuss it with these axes. And trust me, I never thought, I always show this axis in the class and always tell that I am only telling you so that you don't have that kida in your mind that you are going to, sir, how does this change of position help in the intubation? But I always thought ki, at least I tell you the physics, it takes 5 minutes to tell you the physics, and they gave this only. And I was very happy to see that what I thought that is going to be very, very important for you is something that came exactly in the exam. So I don't think anybody made a mistake, and we know it is sniffing and we know it is used for intubation. So position of the neck for intubation would not be, because this is position of both head and neck. It is extension at atlanto-occipital joint, which is the part of head, and flexion at lower cervical joints, which is the part of neck. So only saying it is position of the neck for intubation would not be such a correct answer. So the correct answer for this is sniffing position for intubation. And obviously bougie insertion is done to facilitate your tube when you are not able to visualize the vocal cord. So you insert a bougie which is thinner, which can move easily, and then you railroad over the tube, and for that you don't need any change of the position of the head. 4th option, pharyngeal access for what? Ashik, pharyngeal access for what? Now this is a PYQ, and we got it last year in NEET, we got this year also. When do you put the victim in the following position? And the position was this, which was recovery position, and the options were also straightforward: conscious patient with pulse and breathing, unconscious with pulse and breathing, unconscious with pulse no breathing, unconscious with no pulse but breathing. Tell me which of the following is an impossible scenario. Which of the following is an impossible scenario for which we don't have an answer what to do? Which of the following is an impossible scenario where we don't have an answer? Yes, 4th. Unconscious patient with no pulse and breathing. It is not possible that somebody doesn't have a pulse and has breathing. No pulse means cardiac arrest, so the patient cannot be breathing. So this is an impossible scenario, and so we don't discuss this scenario at all. This is an impossible scenario. Rest all the 3 conditions we can do something. If it is a conscious patient, pulse and breathing, don't do anything. No? There is no problem only. Unconscious with pulse and breathing. Yes. Now this is something, the victim is unconscious, non-responsive, but pulse and breathing both are present. That means there is some other problem apart from cardiac arrest. And that is why you put them in recovery position. You turn on one side, one head under the head, one hand under the head and another leg over another in flexed form, so that the patient's weight is on one side and the patient doesn't aspirate. Unconscious with pulse and no breathing, you will give rescue breaths according to the BLS algorithm. This is what we discuss every time in the class, that when there is an unconscious patient, put them in recovery position to prevent choking and then only leave the victim to go call for help. Expected question. MH, air embolism, two very, very important questions that are asked in the exam. This time they asked MH, patient undergoing anesthesia for a surgery suddenly develops increased ATCO2, muscle rigidity and hyperthermia. Which of the following is responsible? And the first thing that we discuss in malignant hyperthermia is it's a genetic metabolic hypermetabolic muscle disorder which happens due to a trigger. And why we discuss it as anesthetics? Because the triggers are anesthetic triggers. What are the triggers? Choline and volatile anesthetic agents. So when I say volatile anesthetic agents, which agents am I excluding? The pure gases, which is nitrous and xenon. So the only option here that had a volatile anesthetic agent was halothane. Propofol IV, nitrous oxide is pure gas and etomidate is also IV. Right? So the correct answer was halothane. What is the technique shown in the image? And I don't think anybody made a mistake, because whenever you have a regional anesthetic technique, where you see a BP cuff being put and there is an IV line. So BP cuff, IV line and a regional anesthetic technique will always be Bayer's block. Bayer's block is also called as intravenous regional anesthesia, which is not done anymore practically because you have better techniques with less risk of complication. But this is something that is asked in the exam, IVRA, which is also called as Bayer's block, where whichever part of the limb, upper limb or distal lower limb that you want to anesthetize, you take an IV line in that only part. You inject the drug after desanguinating, exsanguinating that limb, inflating this BP cuff and then injecting the drug, and this drug will then go into the vessel and diffuse out and block the entire distal forearm or distal leg, and then you can perform short duration surgeries. Now there are two things that you need to remember, that the agent of choice for intravenous regional anesthesia is prilocaine is most preferred, followed by lignocaine, because of the safety, margin of safety. So prilocaine is preferred over lignocaine, and absolute contraindication of a local anesthetic for IVRA is bupivacaine. Why? Because bupivacaine is most cardiotoxic LA, and if you inject a most cardiotoxic LA intravenously, and by chance when you deflate the cuff, at the end of the procedure, all this bupivacaine will directly go into systemic circulation, causing cardiotoxicity, and the patient will not survive, right? So remember these two things for future. Agent of choice is prilocaine over lignocaine. If prilocaine is in the option, that you will mark that, otherwise lignocaine, and contraindicated is bupivacaine. All right. And last question, and this is the only question that we have not discussed in the class, and this was a new question, and it was a question that was least expected, because we do discuss AMBU bag, we discuss the different bag sizes, we discuss FiO2, we discuss everything, but they asked, giving an AMBU bag, what is the pressure that will set off this pressure relief valve which can prevent barotrauma? And the correct answer is actually 45 centimeters of water is the pressure at which this pressure relief valve will set off, but the correct answer here would be 30 to 40 centimeters of water, right? So this was the only question out of the 12 questions that we did not discuss, and this was this one-off question that I'm not expecting anytime in the future. But yes, that these things, they keep on happening. But out of 12, 11 questions came directly from the notes, directly from what we discuss, and we insist that we need to discuss these things, right? So these were the questions in anesthesia that came in your exam, in your NEET PG, in both the sessions, and I hope you all solved them and you like them. Yes, I know. But 40 mm of Hg would be too high a pressure. Whenever we talk about airway pressures, we always talk about centimeters of water. But don't beat yourself down on that, because in the exam, in a new question, you can't possibly think so logically. So I think that is absolutely fine. All right. So if there are no doubts, then I'll like to end the session with this. Again, the thought process. A lot has been going on since few days, and I know there is a lot of negativity around us right now, and we are all agitated and aggrieved, and we are feeling let down. And I know this feeling because this keeps on happening now and again, and we keep on fighting for it. And when I was doing my residency, that time also we had this big issue with the security in the hospital, and we went on a strike, although it was just a college level thing. And we think we are going to make a meaningful change in the society. And you know what? Ultimately, it does make a difference. So no matter how you feel right now, you have to remember that unless and until you stand for yourself, nobody is going to stand for you. So we are all doing our part. Some would be vocal about it, some would not be vocal about it, but by and large, I strongly believe that this event, no matter how unfortunate it was, might lead to something that will change the lives of all the future medicos, not just women at work, but also men at work. And also it changes the perception that we are just machines who are going to just keep on working without getting tired, without getting battered. So I sincerely hope that this entire saga, it comes to a logical end, and we get some hard assurances from the government, and everybody starts believing that we are not somebody who the society can just take advantage of. So my heart goes out for all the people, all the residents of RJKR Medical College in Calcutta, who are at the forefront of this agitation, and who are taking all the pains, and they are the ones who are really putting in, and they are all motivating us to stand for themselves. And of course, my heart goes out to the family of the deceased resident doctor. She was one of our own, and it is never a good feeling to see anybody meet this fate, let alone a doctor. So with my folded hands, I pray that the departed soul rests in peace, and their family gets the courage to deal with this time of intense crisis. I'll hang up the session now.